Hi, welcome to the second part of the antibiotics or antimicrobials in ICU. Yesterday, we were talking about the pharmacokinetics of the antibiotic in the ICU. Today, we will be starting from the point where we end. First of all, thank you for all responses what I am receiving after yesterday's or the last lectures. I will not say lectures, but a small guide for the trainee or the young intensivist who are junior than me, who are currently reading in DRNB or preparing for NEET SS exam or, or having an exit exam of DM and DRNB in near future. So let's start again with the sharing of the screen. So where we ended yesterday for the clearance. We have understand the clearance, the absorption, distribution, metabolism, and elimination part. So after the clearance, we will be coming to the first order and the zero order kinetics for the elimination of the drug. So what is the first order kinetics? The first order kinetics is basically what we mean by the first order kinetics. The rate of elimination is directly proportional to the drug concentration. So that means as the drug concentration increase, the rate of elimination also increase. So what is constant? The constant is the fraction of the drug excreted, not the absolute amount of the drug excreted. In zero order kinetics, the absolute amount of the drug is constant. So even if you increase the concentration of the drug, the rate of elimination remains the constant. So you can see in the graph, the rate of elimination remains the constant. But in case of first order kinetics, which most of the drugs in the ICU follows, is the linear increase of the rate of elimination with the increase of drug concentrations. Because the fraction of the drug which is eliminated is constant. So as you increase the amount of drug intake, or as you increase the amount of drug administered in the body, the amount of drug excreted also increases linearly, because it is the fraction which matters. It is not the absolute number which matters in case of first order kinetics. Whereas in the zero order kinetics, it is fixed. Whatever drug you administered, the fixed amount of drug will be eliminated. So in first order kinetics, most of the drug comes in the list. And for the zero order kinetics, there was a famous mnemonic 0-watt. You can go and see in the Google. So 0-watt was the mnemonic what we used to remember. Warfarin is one of the important drug. The ethyl alcohol is one of the important drug which follows the zero order kinetics. Coming to the compartment model, as you give a drug into the blood, or as you give administered a drug into the blood, or it gets absorbed into the blood, the drug get redistributed from the central compartment to the vessel intermediate and the vessel poor compartment. What is the vessel intermediate compartment? The vessel intermediate compartment is the muscle, and the vessel poor compartment is the fat. So it get redistributed. So as you can see, once the drug is administered, it peaks in concentration. Then it have a slow fall. This slow fall is due to the redistribution. This is the alpha elimination. And again, it has a fall which is basically due to the true elimination out from the body. So this is the beta elimination. So the drug have a two half-life. One is alpha half-life, one is a beta half-life. So basically once it redistributes, it has a fall from the peak, slight fall. And once it gets eliminated, it has a further fall by which it is ultimately eliminated out of the body. And for an example, as you administered albumin, within a few hours of 17 to 18 hours, it gets redistributed. But ultimately, the half-life of the albumin, be it endogenous or an exogenous, it is 18 to 21 days. So it ultimately goes out of the body after 18 to 21 days. But if we consider the redistribution half-life for an exogenous albumin, which is administered from outside, it is 17 to 18 hours. So it is very important. Every drug has basically two half-life. One is it is out from the serum, but redistributed into the vessel intermediate or vessel poor compartment. Again, come back to the central compartment and ultimately it goes out of the body, which is originally the half-life of that drug. Coming to the actual half-life, the half-life is the amount of time taken for the plasma concentration to reduce to the half of its original or the initial value. So as we have seen, it has two phases. One is alpha phase due to the distribution, and later the beta phase due to the elimination. So the alpha phase is due to the distribution, the beta phase is due to the elimination. For the half-life, for one half-life, 50%, second half-life, 70%. Likewise, for the fourth half-life, 93.75% of the drug is eliminated. So it is very important if you administered a drug and for that drug, you need 4 to 5 half-lives for the drug to get fully eliminated. What is the practical application of that? If you want to test a patient for a brain death and you are giving a fentanyl or a midazolam or a sedative analgesic, so you have to wait for 4 to 5 half-life for the drugs to get eliminated and to start the testing. So if a half-life of a drug is X, so you have to wait for a 5X time before you start with the brain death testing or anything to be tested which is out of the effect of that drug, right? So this is very important. You need 4 to 5 half-life of the drug for to get it eliminated from the body. And you can see in this slide that the fourth half-life, 93.75% of the drug is eliminated. So the drug which follows the fast order kinetic, which is most of the drug in our ICU, the formula of the half-life is 0.693 into volume of distribution by clearance. As the volume of distribution and the clearance of the drug following the first order kinetics is fixed, so the T half remained fixed. So for the first T half, second T half, for every T half, the time is fixed because the VD and the clearance are fixed and that do not change with the dose. But in case of zero order kinetics, the clearance decreases. As we have read in our previous slide, the clearance decreases with the increase in concentration of the drug. So the half-life in the drug following the zero order kinetics are not fixed. Now coming to the plateau principle, what we say that in case of a drug, so there is a half-life. So you can wait for the half-life of the drug and you can wait for the concentration to fall and to give a next drug. But we don't do it. We give meropenem 1 gram TDS, right? We don't measure that the drug is completely eliminated out of the body and we will be giving the next drug after the 4 and 5 half-life of the drug so that the drug doesn't get accumulated. So, but we have the intention to maintain a steady state or a plateau state of drug or the plateau dose of drug for which is effective for the patient. So before the drug comes down in the graph, we administer the second dose. Then we administer the third dose. So after a certain period of time, after 4 or 5 half-life, the drug achieve a steady state concentration. So you can see in the last part of the slide, the steady state is reached in 4 to 5 half-life unless the dose interval is very much longer. So if we are waiting for the T half and the concentration of the drug to come down, is the duration is very long, then the plateau will not be achieved. But if we are giving at a fixed interval what is meant to achieve a plateau level of the drug, then subsequently the plasma level will rise. And at a point it will come, what happens during the plateau phase? That the amount of drug administered and the amount of drug eliminated becomes equal. So the patient maintains a plateau phase or a plateau level of the drug. So as you increase the dose of the drug. As the concentration of the drug increases, the rate of elimination also increases. So at one time it reaches that the rate of elimination and the rate of administration become equal. And at that point only, the drug reaches a plateau phase or a plateau level which is effective for the drug to act. So this is known as a plateau principle. So it takes 4 to 5 half-life to reach a plateau level. That is why in a liver transplant ICU, while we are asking for the sister to measure the trough, to send a trough level. When we send a trough level for a tacrolimus, we send a trough level for a tacrolimus after the 4th dose, just before the 5th dose, 30 minutes before the 5th dose. So after the 4 half-life, the drug reaches a trough level. So this plateau level, the trough level, the steady state level, whatever you may say, the concept is the same, that after 4 to 5 half-life, the drug reaches a plateau state or a plateau level or a steady state level. What I said to you, in the steady state level, the rate of elimination is clearance into the concentration of the steady state. So we know that what is clearance? It is the amount of blood from which the drug is cleared off, and the concentration of the drug that totally makes the amount of drug which is going out of the body. So the clearance into the concentration, this makes the rate of elimination. And as the rate of elimination is equal to the rate of administration, so the rate of administration also becomes clearance into steady state concentration. So the maintenance dose become steady state concentration into clearance. So the steady state concentration is equal to the maintenance dose rate divided by the clearance. Why we are discussing this, we will be coming in the next slide. So the next slide, you see for the loading dose. For the loading dose, the target plateau or the target peak concentration, not plateau. For the loading dose, there is nothing plateau. The loading dose, the peak concentration. So the target peak concentration into the volume of distribution. So we are targeting a concentration in the blood, a peak concentration, and which is multiplied by the volume of distribution. So over which the drug will be distributed. That multiplied together makes the loading dose. And what is F? F is the bioavailability. So if you give a drug X and the bioavailability is 90%, so the 0.9 part of the drug will make into the blood. So we have to divide that the target peak concentration into volume of distribution by the bioavailability to get the actual loading dose, because the whole part will not. If the bioavailability becomes 1, so the F becomes 1 and the loading dose is equal to the target peak concentration into volume of distribution. But if the 0.9 is reaching, so you have to divide by 0.9 and it will eventually give you the loading dose, which is divided by the bioavailability. So thus, what is clear from here? That the loading dose is dependent on the peak concentration and the volume of distribution. See, in the loading dose, there is nothing a term of clearance. So why I am reading this? Because so that what it is clear from here. So for a loading dose, when a patient comes into an ICU, you start with a meropen of 1 gram. We often ask, what is the creatinine? The creatinine is 5. So let's give 500 mg. No, that is a wrong thing. For a loading dose, there is nothing to do with the creatinine clearance or creatinine. So the loading dose is depending only on the peak concentration and the volume of distribution. So the loading dose should not be governed by the clearance. That is what I have written, that the loading dose is governed only by the volume of distribution, not by the clearance of the T-half. So whatever the kidney is, you have to give the loading dose full before starting the maintenance dose. And it should be given in the full dose, no dose reduction for the loading antibiotic or the loading drug. For the maintenance dose, as we have known that the dose rate or the maintenance dose rate is equal to the steady state concentration into clearance, because at the steady state concentration, the rate of elimination is equal to rate of administration. So the dose rate is equal to the steady state concentration into clearance, what we have read from the previous slide. Now the maintenance dose become dependent on the clearance. So here comes the role of the creatinine. So for the maintenance dose, we will come down with the dose amount of dose. So that is why we give injection meropenem 1 gram stat followed by 500 mg BD or TDS according to the creatinine clearance, but no compromise on the loading dose. We will be coming to the other reasons of also why we should not compromise on the loading dose in the next slides, as we discuss what is the changes happening in the PKPD during the septic or septic shock. So, but for anything, the loading dose should not be compromised because loading dose doesn't depend on the clearance. The maintenance dose depend on the clearance. So the maintenance dose should be reduced while the clearance is because it depends on the clearance. So as the creatinine is increasing, the maintenance dose should be adjusted, but never the loading dose. This is the takeaway message. And number two, for these and what is written here, the collected 30 to 60 minutes after the infusion and collected 30 minutes. So these are not the loading dose and maintenance dose. Pardon for mistake in the slide. These are basically the peak concentration and the trough concentration. The peak concentration when it is collected, if you are asked in the exam, the peak concentration is collected 30 minutes after the infusion. So as you give the infusion, the concentration peaks. So just after the infusion, after 30 minutes, you collect the peak concentration. But for the trough concentration, you have to wait 4 to 5 half-life. We have already read for the steady state concentration, you have to wait 4 to 5 half-life. So it is collected. It is collected 30 minutes prior to the 5th half-life. So after the 4 dose is given, that is the reason why the tacrolimus trough level is sent on the morning of the 3rd day, right? So we say on the 3rd day, sister, kindly send the trough level of the tacrolimus. Why not? On the 1st day. So if you are sending on the 1st day, 30 minutes after the dose, you are sending the peak concentration of the peak level. But what we want the trough level or the steady state level. It is sent 30 minutes prior to the 5th half-life or after the 4 dose of the drug, right? Now we have already read this thing. Now the question comes, the first trough level of the tacrolimus is sent on which day at the transplant ICU? The answer is very clear, on the morning of the 3rd day, because for 2 days BD dose, 4 dose given, 5th dose on the 3rd day morning. Just before giving the 5th dose of the 5th half-life, we send the drug. So after the completion of the 4th half-life, just before giving the 5th dose, we send the trough level of the tacrolimus. So this concept is clear, I hope. The peak concentration. All of the antibiotic except one is useful for the urinary tract infection. We have discussed. So guess what's the answer? So for urine, for any drug to come in urine, the drug should be hydrophilic, right? What you are guessing is very right. The drug should be hydrophilic. So we will be seeing what are the hydrophilic drugs. Amikacin is a hydrophilic drug. Cefoperazone is a hydrophilic drug. TG-cycline, wait for a minute. Fosfomycin is a hydrophilic drug. For a UTI, we often use fosfomycin sachet. Cefoperazone beta-lactam is a hydrophilic drug. But for the TG-cycline, tetracycline, doxy, TG, Mino are the lipophilic drug. So they get distributed into the tissues. So TG-cycline is excreted having a biliary excretion. So TG-cycline, big no for urine and bloodstream infection. Doxycycline, big no for bloodstream and the urinary infection. Trust me, I have seen many physicians using doxycycline for urinary tract infection. I have seen many physicians using TG-cycline for bloodstream infection. But if somebody is using that, the reason of stopping is very clear, and for this only we are interested in this type of academics or lectures. So the answer is TG-cycline, big no for urine and bloodstream infection, tetracycline. Please stop tetracycline for urine and bloodstream infection. Now coming to the critical illness on the antimicrobial PK. So the pharmacokinetics we have read: absorption, distribution, metabolism, elimination. ADME, what we used to say, assistant DME or assistant director of medical education. So the critical illness, what happens to all these things? There is a hyperdynamic circulation. So there is a constant increased cardiac output. So the amount of blood which is going into the kidney increases. So there is an increased clearance. So the plasma concentration decreases. So if the clearance is increased, if the plasma concentration decreases rapidly, so would you like to decrease the dose of the drug? So a mild AKI or a little bit of increase of creatinine do not decrease the dose of the drug, because if the patient is on septic shock, the patient is in a hyperdynamic circulation, the drug will easily eliminate out of the kidney. If the patient is pouring out urine, don't think of decreasing the drug for the first 48 hours. The altered fluid balance, there is a third spacing. So basically for the hydrophilic drugs, we loves to stay within the central compartment or the blood vessels. As the vessels leaks in the septic shock, there is a third spacing. So the drug goes out of the vessels. So the concentration of the drug decreases in the blood. So whatsoever of the drug reaching to the target organ decreases. So there is an increased volume of distribution. So the plasma concentration decreases. In the middle, if there is nothing like that, the normal plasma concentration. On the other side, what happens in the sepsis, there is a renal and hepatic dysfunction. What we are afraid of: increased clearance, increased bilirubin, increased hepatic enzymes. So there is a increased volume of distribution and the decreased clearance. So thus the plasma concentration increases. As there is a decreased clearance, so the plasma concentration increases. Also, there is the patient is on RRT and ECMO or both. So there is an increased volume of distribution. As there is the patient is in RRT, the drug goes out of the body and it gets recirculated. So the amount of blood with the amount of drug within the blood decreases. So there is a decreased plasma concentration. Sometimes during the RRT and ECMO will be discussed later on, there are conditions where there may be an increased plasma concentration. So for a patient on a septic shock or a critical illness, there are multiple factors which is governing this absorption, distribution, metabolism, and excretion. So we have to look into one by one. We have discussed altered VT. You see in the meropenem, in the septic shock, the volume of distribution is 0.3 to 0.5 liter per kg, whereas the normal patient is 0.1 to 0.2. So if it is distributed more, so the concentration is already less in the blood. So now you are decreasing the amount of meropenem. 1.5 creatinine is there, 1.8 creatinine is there. There is a heroism to decrease the meropenem dose to 500 mg TDS. I know what is creatinine clearance. I'm showing my knowledge, but you are showing a wrong knowledge in the pen and paper, because the VD or the volume of distribution. So if a creatinine would have done any all the thing, so there would have been a big subject called critical care medicine. So as we are into this academics part, so we should be learning, apart from creatinine, there are factors where the volume of distribution should be taken in consideration. The meropenem volume of distribution increases as it is a hydrophilic drug. So it is going out of the vessels because now the capillaries have become leaky capillaries. So the volume of distribution is increasing. So do not come down with the dose. Loading dose, never, never. After the loading dose also, for the 1 to 2 days, if the patient is pouring out urine enough, even if the clearance is high, creatinine is high and the creatinine clearance is low, do not come down of the drug all of a sudden. For the 24 to 48 hours, the patient is in a SARS or in a hyperdynamic circulation with a leaky capillary. The concentration of the drug in the vessel or in the blood is very low. So if you reduce the dose of the drug during this time, the ultimate concentration at the source of infection where you want the drug to be concentrated will be very low. There is a fluid shift in the third spacing we have already discussed. For the protein binding, we do not care about the albumin. We only see albumin when the BP is low, but not only the case where the BP is low. In the hypoalbuminemia, the drugs which are very much bound to the protein get easily excreted through the kidney, because the free amount of the unbound fraction of such antibiotic is also is not only is available easy for elimination, not only for elimination, it also gets distributed. When the drug was bound to protein, it cannot go out of the capillary, the leaky capillary. It would have been distributed into the tissue. It would have been remain in the blood. So we are happy to treat the bloodstream infection with those drugs. Now the albumin level come down and the drug is made free. So the drug will go to the kidney and will get excreted, or it will go out of the leaky capillary and it will distribute it into the tissue. So ultimately what will happen? The concentration of the drug in the blood will decrease. Now the blood has to travel to the brain, or the blood has to travel to the some other distant tissue. It will, as the concentration of the drug decreases in the blood, so it will not achieve certain level which is effective to kill the bacteria. So the protein binding drug, we have to make sure of ertapenem, teicoplanin, ceftriaxone, daptomycin are very much protein bound. So if you are seeing albumin level is low, do not reduce the dose of these drugs all of a sudden. Creatinine is there, but if the patient is pouring out urine, if the patient is in the initial part of the shock, try to maintain as much high dose as possible, considering your clinical knowledge at the bedside, which is most important, the thing apart from these theoretical lectures. But apply these logics also. The highly protein-bound antibiotics such as ceftriaxone, daptomycin, ertapenem, teicoplanin, vancomycin are found to be increased. The VD are found to be increased in the critically ill patient with hypoalbuminemia. So as the VD increase, if we come down with the dose of the drug, so the ultimate concentration of the drug in the blood will eventually decrease. So it is very important that these drug doses should not be reduced all of a sudden, at least during the 48 hours of the septic shock. But the tissue perfusion, as the tissue perfusion gets low, the drug distribution also gets low. So in certain areas, the drug cannot reach due to the tissue perfusion. That is a problem in the septic shock also. And also you have to take care for which side you are. Some drugs are highly permeable to CNS. Some drugs are very less permeable to CNS. So also you should take in consider of those factors. And in the critically ill patients with septic shock also have a decreased microvascular perfusion, and so the reaching the dose drugs to the alveoli, to the cerebrospinal fluid or the soft tissue may get hampered due to this poor perfusion. So you have to also maintain the cardiac output or the perfusion for reaching those drugs. So why? So these are the reason why we say ki we are giving proper antibiotic, we are giving meropenem, we are giving poly B. Why not it is acting? Because there are a lot more factors between the meropenem and poly B and the critically ill patients. There are many factors in between these two, which is very important to consider while giving a antibiotic or a drug. There is an augmented renal clearance. What happens in the sepsis? The clearance becomes, the creatinine clearance is almost greater than 130 ml per minute. You can see in some septic patient, there is a very high sepsis or a septic shock, not very high sepsis with a very good term. There is a septic shock and the patient is not increasing of creatinine. We are expecting now it's a time that the patient should get its creatinine increased. But what happens due to the hyperdynamic circulation, the creatinine gets circulated again and again from the kidney. So the creatinine takes time to increase. More or less, the old patient with septic shock has a very decreased muscle mass. So the creatinine is not actually, when the creatinine start rising, almost 50% of the renal function is gone. So creatinine is very late to rise. So why I'm saying this? Because in the augmented renal clearance, also as there is an increased clearance of the creatinine clearance, of the clearance of the drug during the sepsis. So we should not also come down with the doses of the drug at the very initial stage of the sepsis of the first 24 to 48 hours. These are the factors where the augmented renal clearance are easily seen. Critically ill patient with sepsis or septic shock, young patient, trauma patient, neurosurgical patient, burn patient. See, whatever the condition you are seeing are basically the patient with an hyperdynamic circulation, basically a patient with a high cardiac output. In burn, in a trauma patient, the cardiac output increases, and the patient lands in the hyperdynamic circulation. In a critically ill patient with sepsis or septic shock, so in those conditions, the uh, creatinine clearance increases up to the level of 130 ml per minute. And this augmented creatinine clearance or the renal clearance decreases the concentration of the drug in the blood. So we should not decrease the dose of the drug in the 24 to 48 hours. Initial 24 to 48 hours, be very cautious to adjust the dose of the drug. It seems very heroism to you that writing 1 gram stat followed by 500 mg TDS. I know what is creatinine clearance, but apart from the creatinine clearance, there are so many of factors which you should consider. So do not come down abruptly with the dose of the drug in the first 24 to 48 hours. So these are the factors we have already discussed. The kidney dysfunction is of area where you should be cautious. In the sepsis, where you should make a dose adjustment according to the creatinine clearance. The concentration dependent agents like aminoglycoside and daptomycin, it is better to prolong the dosing interval while maintaining the unmodified dose amount. So as we need a concentration dependent, we need a peak concentration. So maintain the amount of drug and increase the dosing interval. Normally we give within the 30 minutes, but you maintain increase interval, and the amount of drug better to unmodify those drugs. The conversely, for the time-dependent agent, it is better to reduce the dose of the drug while maintaining the unmodified dosing interval. So for the time-dependent, we do not need a peak concentration because it is not concentration dependent. We will be coming to this later. For the time-dependent antibiotic, we will be reducing the amount of dose of the drug, but we will not be prolonging the interval, because as we are decreasing the dose of the drug, if we are prolonging the interval, then the concentration will not be achieved above the MIC. So these are the small thing we have to keep in mind, that for the time dependent antibiotic like beta lactam, it is better to reduce the dose while maintaining the dosing interval. For a concentration dependent antibiotic, better to prolong the dosing interval. We are giving 30 minutes, increase it to 1 hour or 2 hours, but do not change the dose. Like in aminoglycoside, do not change the dose because we have to reach a peak concentration, because it's a concentration dependent antibiotic. For a time dependent antibiotic, you come down with the dose because it is nothing to do with the peak concentration, but we need the drug to be above MIC for a certain period of time. So for the drug to be up, as you are coming down with the dose of the drug, and if you prolong the infusion, then the concentration will never go above the MIC. So you maintain the duration of the infusion and you come down with the dose of the drug, as we don't need a peak concentration in the time dependent antibiotic. We are going a little bit slow in this part because these are the concept you need to remember while dealing with the antibiotic in the ICU. For the hepatic dysfunction, the drugs which are has a high hepatic extraction, they are dependent on the hepatic blood flow, which has a low hepatic extraction. They are mainly dependent on the enzymes, the induction and the inhibition of the enzymes, because they have a very low amount of extraction. So the blood flow, until and unless it reaches to the critical value, doesn't hamper the extraction of those drugs. But how it is eliminated? Then whatever drug it is extracted, it's metabolized by the enzyme. So if the enzymes is induced or inhibited, then the amount of drug metabolized will increase or decrease in case of low hepatic extraction. So low hepatic extraction, enzymes. High hepatic extraction, blood flow. You have to remember this too from this slide. So these are what we have discussed. You can read by pausing the slides. So we have almost done to the pharmacokinetics. We have complete with the pharmacokinetics. Now the pharmacodynamics. Pharmacodynamics is D for drug. So what drug does to the body? So it is basically the pharmacodynamics is what it means that the what drug will do to the body. It is basically at the receptor level, it is at the effector level, what the body drug does to the body. So these are the two terms, potency and efficacy. So what is efficacy? Efficacy, here see that there is a four drug A, B, C, D. The drug B is less potent but equally efficacious as drug A. So because as the response, highest possible response reached by the drug A and B are equal, so these two drugs are efficacious, no doubt, equally efficacious because they are reaching the highest response, both are reaching the same highest response, but C and D are not reaching so much of highest response. So C and D are less efficacious than A and B. But now comparing A and B to reach the that amount of response, the A require a low concentration where a B require a high concentration. So that means they are both are equally efficacious, but A is more potent. A is more potent, so it reaches the high response or the equal response to B, but with a low dose or a low concentration of the drug. So A is more potent, B is less potent, but both are equally efficacious. But C and D are less efficacious than A and B. But while considering C and D, D is more potent and C is less potent, right? So these are the things what we have read in the pharmacology is just a recapitulations of those concepts. So the upper limit of the drug response curve is the index of the drug efficacy and refers to the maximal response that can be elicited by those drugs. So efficacy is more decisive of choosing a drug because ultimately we have to reach a goal. So now we reach with a small concentration, we reach with a high concentration, that matters little than reaching the ultimate goal. So the efficacy is more important while choosing a drug than the potency. So the low hepatic extraction drug is affected by thing. Yeah, what you are saying is right. As it is a low hepatic extraction, so it will be affected by enzymes, not by the blood flow. So the answer is induction of hepatic enzymes. So the blood flow will not affect those drugs which has a low hepatic extractions. Now coming to the minimum inhibitory concentration. So now the drug will act on the bacteria. So this is a part of the pharmacodynamics. So the drug will act on the bacteria. So what do you mean by the minimum inhibitory concentration? Look into this picture very carefully. There is an test tube which are arranged serially. Now the antibiotic concentration is doubled in one after the test tube. Now you see in the first test tube it is turbid because there is the bacterial growth. In the second test tube, it is less turbid and at the concentration of antibiotic 1 microgram per ml, the test tube is cleared of the bacteria. So this is known as the MIC or the minimum inhibitory concentration. What do you mean by that? The lowest concentration of the antimicrobial or the antibiotic that results in the inhibition of the growth of a microorganism. So it causes the inhibition of the growth of the microorganism. The minimum or the lowest concentration which is causing it is known as minimum inhibitory concentration. But remember, I have said inhibited. Inhibition is doesn't equals to death. So the bacteria are still alive. We cannot see the turbidity. So this is the concentration at which the bacteria's growth is inhibited. It is not dead. So what is minimum bactericidal concentration? So now in the previous slide, if we have taken this 0.5 ml of this mixture out of the test tube and grown on a petri dish containing the culture media, then the bacteria would have grown because that petri dish is free from the antibiotic, right? So this doesn't mean that the bacteria has become dead. So you see, in the MIC, there is clearance of the test tube. It's right. The 2 microgram per ml is the MIC here. But when it is recultured in a petri dish, the bacteria is growing. But at 4 microgram per ml, the bacteria is not growing. So the 4 microgram per ml becomes the minimum bactericidal concentration. So minimum bactericidal concentration is the lowest concentration of an antimicrobial agent required to kill a particular bacterium. Now the term comes kill a bacteria. Previously it was inhibit the growth of bacteria. So how it is determined? It is determining the subculturing to an agar plate. When we are subculturing in an agar plate, if it is growing, then it is MIC. If it is not growing after the clearance in the test tube, there is no visible growth in the test tube, then it is MBC. So what we are doing, we are increasing the dose of the antibiotic and we are testing this. So this is the MIC and this is the MBC of a drug for a particular strain of organism. What I mean by that, the MIC of an organism differs from patients to patients, differ from source to source, differs from condition to condition. It is not same. E. coli MIC will be same for all the patients in the ICU. No, what is same for all the patients of the ICU is the breakpoint, which we will be discussing in the next lecture. So what we finish over here, the relation between the MIC and MBC. So if the MBC and MIC are very close, so we decide the drug on basis of MIC. So if we are achieving MIC and subsequently we are achieving almost MBC almost at the same concentration or less than the 4 times of the MIC, then the drug become bactericidal because we cannot have the luxury of giving the drug to the concentration of MBC because inhibition of the growth is enough for the patient to recovery. Rest the immune system will take care. So if the patient's MBC by MIC is less than 4, then the drug become bactericidal. If the MBC by MIC is greater than 4, then the drug become bacteriostatic. So it is a very important concept. By this, we end the part 2 of the antibiotic. We will be continuing with the part 3 of the antibiotic with much more details with the breakpoints, limitations, finding breakpoints, efficacy ratio, MIC creep, how to determine different susceptibility, D-test. We will be reading why the colistin is given, what is the susceptible and resistance mean, what do you mean by the intermediate category, why the colistin is always given I, PKPD, time dependent, dose dependent, lot more to learn. So see you on the next video. Thank you for tonight.